My name is Jessica Zoladz, and I'm a certified genetic counselor at Natera. This presentation will explore the clinical aspects of Lynch syndrome, formerly referred to as hereditary non-polyposis colorectal cancer, or HNPCC. It will also highlight Natera's hereditary cancer testing product, Empower. Lynch syndrome is a condition that affects 1 in 300 to 1 in 500 individuals in the general population. It accounts for 2 to 3% of all colorectal cancer and 5% of all endometrial cancer. That number increases to 9% in women diagnosed under the age of 50. Lynch syndrome significantly increases the lifetime risk for colorectal and endometrial cancers, as well as others such as pancreatic, ovarian, and gastric. It is caused by pathogenic variants or mutations in 5 genes: MLH1, MSH2, MSH6, PMS2, and EPCAM. It is inherited in an autosomal dominant manner, which means that only one variant or mutation is needed to establish the diagnosis. Here you can see the lifetime cancer risks for individuals with Lynch syndrome, represented in green. The blue bars represent general population risks. Endometrial, colorectal, and ovarian cancer risks are significantly increased compared to the general population. While traditionally thought of as a colorectal cancer risk syndrome, women with Lynch syndrome, as you can see, have a higher risk for gynecologic cancer. There are several genes known to be associated with an elevated lifetime risk for ovarian cancer. The most well-known of these, of course, are BRCA1 and BRCA2. BRCA1 and 2 are commonly referred to as the BRCA genes and cause hereditary breast and ovarian cancer syndrome. In this graph, the dashed line near the bottom represents the lifetime ovarian cancer risk for the general population. The purple bars represent gene-specific estimated risks. While the highest ovarian cancer risk is linked to pathogenic variants in BRCA1, you can see here that the 5 Lynch syndrome genes also infer an increased risk. Variants in MSH2 and EPCAM can have up to a 38% lifetime risk for ovarian cancer, a risk that's higher than that of BRCA2. Oftentimes, when a patient has a personal or family history of ovarian cancer, providers will intuitively think of these BRCA genes and order testing only for these 2 genes. Unfortunately, in doing so, many women with Lynch syndrome are missed and may be falsely reassured. They will not realize, for example, that they are also at increased risk for colorectal cancer. As I mentioned at the beginning of this presentation, Lynch syndrome is no longer referred to as HNPCC. It isn't just colorectal cancer. Lynch syndrome women in particular have a risk for endometrial cancer that equals or exceeds their risk for colorectal cancer. These patients are in your OBGYN practice. More than half of the time, the first cancer these patients are diagnosed with is a gynecologic one. But arguably, identifying these patients after they're diagnosed with cancer is a failure. There are numerous published studies that have documented the efficacy of various medical management options to reduce cancer risk in Lynch syndrome individuals. That means the best time to diagnose someone is before they get cancer. Similar to why carrier screening is best done preconceptionally, hereditary cancer testing done before a cancer diagnosis empowers the patient to take preventive actions. Their risk-reducing options include increased surveillance, prophylactic surgeries, and chemopreventive medications. In the following slides, we will review the guidelines that are in place to manage cancer risks associated with Lynch syndrome. But first, I want to highlight some of the warning signs that can alert you to patients who may be at risk for Lynch syndrome. These are helpful to keep in mind, especially when taking a family history. The first is colorectal or endometrial cancer, less than 50 years of age, whether it's a personal history or a family history. Generally speaking, any cancer diagnosed under the age of 50 is a warning sign for hereditary cancer syndromes. 2 or more Lynch-associated cancers in the same individual or on the same side of the family is also an indication that your patient may be at risk. As a reminder, Lynch cancers can include colorectal, endometrial, ovarian, gastric, pancreatic, and less often, brain, urinary tract, and small bowel. So what can patients with Lynch syndrome do to reduce their cancer risks? I want to point out here that these guidelines are included on each and every Empower report. They are not something that you'll have to remember or search for. Increased surveillance via colonoscopies every 1 to 2 years, as well as annual pelvic exams, endometrial biopsies, and CA-125s are recommended. The rationale for frequent colonoscopies has to do with the fact that cancer progression in Lynch patients is much faster than it is in the general population. Typically, it takes 5 to 10 years for an adenoma to progress to invasive cancer in the general population. That progression, however, occurs in 1 to 3 years in a Lynch syndrome individual. Prophylactic total abdominal hysterectomy with bilateral salpingo-oophorectomy is also an option for Lynch-positive females. Additionally, patients can be referred to gastroenterology for monitoring all of the upper and lower GI risks associated with Lynch syndrome. Neurology can monitor for CNS-related risks as well. Some studies have shown that 600 milligrams per day of aspirin for up to 4 years can decrease colorectal cancer risk. A study from 2008 randomized 639 patients to either aspirin or placebo and showed a protective effect of aspirin. Therefore, aspirin could be an effective chemopreventive option for Lynch patients, although there isn't yet enough data for an official recommendation. Oral contraceptives can reduce the risk of endometrial and ovarian cancers in the general population by up to 50%. Therefore, Lynch syndrome patients can consider taking OCPs. Progestin therapy is also standard of care for treatment of endometrial hyperplasia and early onset endometrial cancer in the general population. And so, progesterone-only IUDs can reduce endometrial cancer by up to 50%. At this point, I would like to officially introduce Empower, a high-quality hereditary cancer test that we have made accessible for all patients. Empower screens for up to 53 genes that are associated with 8 common hereditary cancers: breast, ovarian, endometrial, colon, gastric, melanoma, pancreatic, and prostate. We utilize next-generation sequencing to analyze single nucleotide variants, indels, and copy number variants. All positive findings are confirmed with an orthogonal technology. We have 4 different panel options to best meet the needs of your practice. While our smallest panel includes only the BRCA1 and 2 genes, all of the Lynch syndrome genes can be found on our 19, 40, and 53 gene panels. We realize that incorporating hereditary cancer testing into your practice can be challenging. Natera Core is a suite of services that can support both in-office and remote workflows. Thank you so much for listening today. To learn more about hereditary cancer testing, please visit natera.com/empower or call 844-778-4700.